Hello everyone and welcome back to our MRCP Part 2 High Yield Revision Series. I am Dr. Wala Eldin and here we go now.
Hello and welcome to our topic about adult advanced life support for MRCP, prepared by Dr. Wala Eldin Ahmed via our YouTube channel, MedPulse. This video is intended for educational purposes only and reflects clinical guidelines commonly used in MRCP Ireland and UK standards and current medical practice at the time of creation. The content does not constitute medical advice and must not be used as a substitute for professional clinical judgment or consultation with a qualified healthcare professional. Clinical decisions should always be based on individual patient assessment, local policies, and the most up-to-date guidelines. Okay, so let's start right there. The absolute foundation. CPR basics. The ratio hasn't changed, has it?
No, the golden ratio stands firm. It's still 30 chest compressions to 2 ventilations. That's the standard.
But there's a specific instruction in the guidelines about the defibrillator that really gets at that efficiency theme you just mentioned. It's what you're doing while the machine charges.
This is such a critical point. You used to see teams where everyone would sort of step back while the defibrillator charges up. It might only be 5 or 6 seconds.
But that's 5 or 6 seconds of no blood flow.
Zero blood flow. The 2021 guidelines are explicit. Chest compressions must continue while the defibrillator is charging.
So you are hands-on pumping the chest right up until the last possible moment.
Correct. You only pause when it's fully charged and you're ready to deliver the shock. You minimize that hands-off time. Every time you stop, the coronary perfusion pressure just plummets.
Okay. Keeping the pressure up is key. Now, while we're doing these high-quality compressions, the team leader has to make that first big decision, the fork in the road.
This is the decision that dictates everything else that follows. You're looking at the monitor and you're putting the patient into one of 2 camps, shockable or non-shockable.
Okay, let's define the shockable camp first. What rhythms are we talking about?
The shockable rhythms are ventricular fibrillation, that's VF, and pulseless ventricular tachycardia, or Pulseless VT.
And how should we visualize those? What's happening in the heart?
Think of it as chaotic energy. In VF, the heart muscle is just quivering. There's electrical activity, but it's completely disorganized. In Pulseless VT, it's beating so fast, it can't actually fill with blood, so it's not pumping anything.
So in both cases, the electrical system is active, but it's malfunctioning.
Exactly. And that's why a shock can help. It's like a hard reset.
And the non-shockable side?
That would be Asystole, the flatline, and pulseless electrical activity, PEA.
PEA is always the tricky one, isn't it?
It is, because you might see a normal-looking rhythm on the monitor. The electrical wiring is firing just fine, but the muscle isn't responding. There's no actual pump. So shocking it won't help. Electricity isn't the problem.
Got it. Okay, let's walk down the shockable path. We see VF on the monitor. We're charging during compressions. What's the immediate strategy?
The strategy is a single shock followed immediately by 2 minutes of CPR.
And I want to emphasize that word, immediately. The instinct is to shock, and then everyone stares at the monitor to see if it worked.
That instinct is wrong. You have to fight it. Even if the shock worked, the heart is stunned. It's not going to generate a strong pulse right away. It needs support.
So you shock, and you go straight back on the chest.
Straight back on the chest for 2 minutes. Don't look at the monitor. Don't check for a pulse. You just pump.
Okay, shock, then 2 minutes of work. Now, drugs. This is where the exam questions get really specific. If I'm on the shockable pathway, I can't just give adrenaline whenever I feel like it.
Absolutely not. In a shockable arrest, electricity is the priority. Adrenaline is important, but we don't give it immediately in VF or VT.
So what's the rule? When does it go in?
The rule is this. You give adrenaline 1 milligram once chest compressions have restarted after the 3rd shock.
After the 3rd shock. So we've done shock 1, CPR, shock 2, CPR, then shock 3.
And then as you restart CPR after that 3rd shock, now you push the adrenaline.
And is that a one-off dose?
No. Once you've started adrenaline, you repeat that 1 milligram dose every 3 to 5 minutes for as long as the code runs. So basically every other cycle.
Okay, that's adrenaline. What about the antiarrhythmic? We're trying to tame this chaotic rhythm, so we're using Amiodarone.
Correct. Amiodarone is the go-to here.
Does it follow the same timing?
It does. It aligns with that 3rd shock. You give Amiodarone 300 milligrams to patients who are still in VF or Pulseless VT after 3 shocks.
So that 3rd shock is a really busy moment. You're pushing adrenaline and Amiodarone.
It's a critical milestone. The team needs to be ready for it. You flush the adrenaline, and then you give the Amiodarone bolus.
Is that the only dose of Amiodarone?
There is a second dose if needed. If they are still in VF or PVT after the 5th shock, you give a further 150 milligrams.
Okay, so 300 after the 3rd, 150 after the 5th. What if, the crash cart is out of amiodarone? Does that happen?
It can. The guidelines are pragmatic. If amiodarone is unavailable, lidocaine can be used as an alternative. But for the MRCP, amiodarone is the primary answer.
Right. And before we switch to the non-shockable side, how are we getting these drugs in? I mean, an IV line is standard.
Yes, IV access is first line. But let's be real, finding a vein in a patient with no blood pressure can be a nightmare. The veins just collapse.
So what's the backup plan?
The standard alternative now is intraosseous IO. You're drilling directly into the bone marrow.
Usually the tibia or the humerus.
Exactly. It sounds a bit brutal, but it works beautifully. The marrow cavity doesn't collapse, and drugs get into the circulation incredibly fast.
Now, here's a specific point from the source material about what's out. I definitely remember learning you could squirt drugs down the endotracheal tube in a pinch.
That's a relic of the past. The 2021 guidelines are very clear. Delivery of drugs via a tracheal tube is no longer recommended.
Why not?
It's just too unreliable. You have no idea how much is being absorbed, what the blood concentration is. It's a total guessing game, so it's IV or IO. If you can't get a vein, drill the bone.
Okay, that covers the shockable side. Now let's flip the coin. We're looking at the monitor, and it's flatline. Asystole, or PEA, the non-shockable side.
This is a very different beast, and the drug timing is completely different from what we just discussed.
How so?
Well, think about it. We can't shock them. That tool is off the table. So we're relying entirely on CPR to move blood and adrenaline to squeeze the vessels. We can't afford to wait.
So no waiting for 3 cycles of shocks.
None! The rule for non-shockable rhythms is adrenaline 1 milligram is giving as soon as possible.
The moment you have access, you push it.
The second that line is in and flushed, you push the adrenaline, and then, just like on the other side, you repeat that 1 milligram dose every 3 to 5 minutes.
It makes sense when you think about it that way. Shockable is electricity first. Non-shockable is drugs first.
That's it. That is the high-yield takeaway.
There's another what's out moment here, too. Atropine.
Yes. For years, atropine was standard for asystole, trying to speed up the heart.
And now
It's gone. Atropine is no longer recommended for routine use in cardiac arrest. The evidence just showed it didn't improve outcomes, so they removed it to streamline the algorithm.
I love it when they remove things. Makes the exam easier.
And it declutters the code. You're focusing only on what works.
So we're running the code, we're doing the mechanics, but if that's all we do, we're not fixing the patient. We have to be thinking about why this happened.
Correct. You have to be a detective. While the team is doing the physical work, your brain needs to be cycling through the reversible causes. The 4 H's and 4 T's.
Let's run through them. The H's.
Right. First, hypoxia. Is the airway patent? Is the tube in? Second, hypovolemia. Is the tank empty? Bleeding? Trauma? Third, hypothermia. Is the patient cold?
And the 4th H is a big group, the metabolic stuff.
Yes, that's hypokalemia, so potassium issues, hypoglycemia, hypocalcemia, and acidemia.
Okay, those are the H's. Now for the T's. These feel more mechanical.
They are. They're often structural problems. First, thrombosis. This is a huge one. Coronary thrombosis, so a heart attack, or pulmonary, a PE.
Okay.
Second, tension pneumothorax, air trapped in the chest. Third, tamponade, so fluid around the heart. And finally, toxins, an overdose or poisoning.
It's such a vital checklist because if you have a tension pneumothorax, no amount of adrenaline is going to fix it.
Exactly. You need to stick a needle in their chest. That can be the thing that saves them. If you miss it, you lose.
Speaking of those causes, the material highlights 2 special circumstances that really change the rules. First one is pregnancy.
Yes, cardiac arrest in a pregnant woman beyond 20 weeks. It's a terrifying scenario, but the fix is all about simple physics.
What's the problem?
It's the gravid uterus. The baby and the womb are heavy, and when the mother is lying flat on her back, that weight crushes the inferior vena cava.
It kinks the hose for blood returning to the heart.
Precisely. It cuts off venous return. You can be doing perfect CPR, but if no blood is getting back to the heart, you're pumping an empty chamber.
So what's the fix?
The immediate solution is the left lateral tilt. You need to tilt the patient's body about 15 degrees to her left.
And how do you do that in practice?
You can place a wedge or even just pillows under her right hip or buttock. Or one person can be designated to just manually push the uterus to the left. The goal is just to roll that weight off the big vessels.
Got it. And the second special circumstance is a suspected pulmonary embolism.
Right. If you have a high suspicion that a massive PE is the cause of the arrest, you consider giving thrombolytic drugs, clot busters.
Like Alteplase.
Exactly. But here's the catch. Those drugs take time to work.
So you can't just give the drug And then stop CPR after 20 minutes if there's no pulse.
You can't. And this is a key exam point. If you give thrombolytics for a PE in cardiac arrest, CPR must be continued for an extended period. The guidelines say 60 to 90 minutes.
Wow. 60 to 90 minutes. That's a marathon.
It is exhausting. But you have to give that drug a window to work. If you stop at 30 minutes, you might have quit just as the clot was starting to dissolve.
That is a crucial number to remember. Okay, let's imagine the best case scenario. We got ROSC, return of spontaneous circulation. The patient has a pulse back. Are we done?
Not even close. Post-resuscitation care is critical, and the guidelines have a very specific warning about oxygen.
Right. The temptation is just to leave him on 100% oxygen. Flood the system to be safe.
That was the old thinking. We now know that hyperoxemia, too much oxygen, is harmful. It causes oxidative stress and damages those fragile neurons.
So doing more is actually doing harm.
In this case, yes. So the guideline is to titrate the oxygen.
And what's the target?
You want to achieve oxygen saturations of 94% to 98%.
If they're sitting at 100% on the monitor, you actually turn the oxygen down.
You turn it down. You want normal physiological levels, 94 to 98%. It's all about precision.
Okay, we've covered a huge amount of detail. Let's do a rapid-fire recap for anyone prepping for their exam. Ready?
Let's do it.
Compression to ventilation ratio.
30 to 2.
Charging the defibrillator.
During chest compressions.
Adrenaline timing in VFVT.
After the third shock.
Adrenaline timing in Asystole PEA.
As soon as possible.
Amiodarone timing.
300 milligrams after the third shock, 150 after the fifth.
What about atropine?
Gone. No longer recommended.
Pregnant patient arrest.
Left lateral tilt. 15 degrees.
CPR duration after thrombolysis for PE.
60 to 90 minutes.
And the target oxygen saturation after ROSC.
94% to 98%.
Perfect. You know, what stands out to me is how these guidelines have evolved. It's less do everything and more do what works.
That is the perfect way to put it. We've moved from frantic activity to a calculated strategy. The focus on things like stopping tracheal drugs, abandoning atropine, and putting an upper limit on oxygen, it shows we're following the data on what actually saves brains and lives. It's not always about doing more.
Well, for our listeners, whether you're sitting the MRCP or just keeping your skills sharp, I hope this makes that algorithm on the wall look a little more like a clear roadmap.
Stay curious and know your algorithms.
A huge thank you to Dr. Wala Eldin Ahmed in the MedPulse channel for the excellent source material for this. And thank you for listening to this deep dive. We'll see you next time.
If you like this series, please hit the like button and subscribe for videos like this. Bye for now.